bold ideas that are very much related to the practice of family and the research of family science. She really has spent a career trying to connect learners with this science, with experiential learning, and she very much wants all clinicians from all disciplines to have a real sense of the meaning of family practice. She is the founding editor of the Journal of Family Nursing. Currently, she is an international educator and consultant about family, but also helping with family intervention research. So it's a very specialized specialty. She was on the faculty at the University of Calgary and helped to create a unit called Family Nursing Unit. This was very experiential learning as well as evidence-driven and evidence-deriving. She created this experiential learning with good colleagues, Dr. Lorraine Wright and Dr. Wendy Nelson. And together they co-developed the illness beliefs model. And this is available in text book form. She was actually one of the 4 founding members of the International Family Nursing Association. It's really remarkable to think what she helped to begin and where that organization is now. She was indeed on the first board of directors for that association and currently continues in a major leadership position within that organization. And now, please, if I may offer you formal comments about Dr. Feetham, and then, of course, my informal. But Dr. Feetham, likewise, is nationally and internationally known and has taken her research into policy such that it directs the healthcare that we are able to give in this country at the level of family. Now, she's had major responsible positions in this country, and I'd like to start with her federal responsibilities. She was the Deputy Director at the National Institute of Nursing Research. She also had a major leadership position in the HRSA, or Health Resources and Services Administration. I have been so excited to see how her science in genetics has been brought forward and embedded within her science of family. It's remarkable to see how she has taken those 2 fields and blended them to help all of us ask new questions. I think one of the most exciting parts of how she thinks is that she has changed all of us from looking at family deficits to family strengths. She has created an instrument that we have now had translated in more than a dozen languages to look at family strengths. And I am thrilled about the new data, the new questions that are supported by that instrument. We here at Children's National have a special closeness with Dr. Feetham. She was here as a full-time employee, the Director of Nursing Education and Research from the early 1980s to 1990, and continues in a major role with us as a research consultant. She also held the first Harriet Worley Endowed Research Chair at the University of Illinois. What makes that incredibly special is not just the honor and the prestige of that position, but that it represented her research mentor, Dr. Harriet Worley. Very, very special. For us, another special aspect is that in 2011, Dr. Feetham was inducted as a living legend, the highest honor that the American Academy of Nursing can award. And then at Wayne State, she was given an honorary degree, Doctor of Law. It's just really remarkable what she has accomplished in her career across disciplines and across specialties. Well, now I'd like to tell you just a little bit about how I see Dr. Bell and Dr. Feetham. And I'd like to start with talking about each one is a master teacher. And that's what you're going to see today. You are going to see 2 master teachers at work. And a master teacher is a person who has a deep understanding of content and how to share that content and doesn't hesitate, just naturally conveys competence. A master teacher just thinks outside of the box and does that in order to think in a way that can convey knowledge, and does it by creating meaningful learning activities. A master teacher is a lifelong learner and leader, passionate about content, an authority, and a specialist. So if we put all that together, what we can say about Dr. Bell and Dr. Feetham is that today we're going to see their wisdom, we're going to see their commitment to family research. I would say we're going to see two sages in action. So if I could share with you then the flow that we are planning for today. First, Dr. Feetham is going to provide us with a state of the science about family research. This is foundational to all that we are able to do now and imagine in the future. She will be followed by Dr. Bell, who will take us into the future by talking about the scientific needs that can be priorities for publication. And then we're carving out special time for all of us to exchange ideas, comments, pose questions. At any point in time, should you need anything, please do let Mrs. Stella Johnson or me know about that. Now, Eileen, would you like to speak to the attestation?
Yes, I'm getting a little bit of echo if someone's not on mute. I just want to say that the notice for requirement for successful completion, we are offering both CNE for nursing and CME for our physician colleagues and others who've joined who would like to claim CME. At the conclusion of this session, you'll receive a link in the chat that will take you to the actual evaluation form. You'll complete that evaluation form and you'll then be able to print your certificate. For those who are interested in claiming CME, I'll also post that information. You'll go to the standard, either create an account or you'll use your own account that you already have for CME. I want to share with you that the planning committee and the presenters today have no conflicts of interest, and this event is being sponsored by the Division of Nursing, Department of Nursing Science, Professional Practice, and Quality. Thank you. And we'll post those links again and the QR codes at the end of the session.
Thank you so much for that, Eileen. And please, may I ask if all of us, except Dr. Feetham, could please put ourselves on mute? And I thank you for doing so. Dr. Feetham, we welcome you and your comments.
Welcome to all, and so appreciate the numbers who are joining us today and from our colleagues really around the world. A very exciting time. I appreciate that I've been involved with all three of the family research workshops at Children's National. And you will see some outcomes from the first two workshops today will be evident in what I present. Today, we'll see a brochure on research with families that emanated from colleagues who were at the second workshop, and also from the second workshop, colleagues presenting at that engaged additional colleagues from other countries and presented a pre-conference at the International Family Nursing Association meeting last year, and are currently working on a manuscript sharing the latest science and guidance to developing family interventions. So very exciting outcomes from the previous two workshops. In recognition, many of you know this has been a long journey for me, and I was very privileged that my doctorate is in family science from Wayne State University in Detroit, or in Lansing, Michigan. I commuted 90 miles from Detroit to get my doctorate at Michigan State University. And the much information and education I received there has really grounded me, and you will see it coming forward in my slides today. I so respect engagement with our colleagues around the world and how you are in our IFNA meetings and other meetings, you challenge thinking and really advance. Of course, we always would want to recognize the families in our care and our research. And many of you know the story of Anne, child I took care of when I was a senior undergraduate student and Anne was a 3-month-old. It is exciting for me that she's been on my shoulder for my entire career. And I have contact with her today, some 61 years later. So very trajectory in recognition of our families is very important. And also, as Dr. Heinz mentioned, I've been at Children's National originally in 1982 to 90 and have the good privilege of being back. And I so want to thank Stella Johnson, Eileen Ng, and Dr. Heinz in organizing the session for today. I would be interested in those of you who are not nurses attending the session today, which I geared this to anyone. If you could put what disciplines you represent if you are not in nursing. The purpose this day is to really bring forward, and for me again, the essential components for researcher family and to advance the science. And what I've stressed for years that we need to include a definition and conceptualization of family and how it informs all aspects of our research, from the question to the dissemination. And I proposed, as I was thinking and working on this presentation today, that if we don't define family in our research, if we don't conceptualize family as to what is the family and who is the family, then I really believe we are starting out on a journey of our research, missing the first part of our map, that we are jumping in, who knows where, onto the journey of our science, really not identifying the essential elements to get us started on that journey. You will also note that, as in this slide and others, I have emphasized policy. And I just attended the first presentation of a project by the National Academy of Science, Engineering, and Medicine. And it's a new project on how identifying federal policies that affect health equities and disparities. And was pleased to see Dr. Felicia Collins, who I worked with at HRSA, as the lead in the Office of Minority Health for that project. An important thing that she mentioned, and I think we should think about as we do all of our work, and I will focus on how do you identify policy. She stressed today that when there's no policy, is a policy. It is indicating the priorities at the national level in our countries, at the state levels in our countries. So think about that as we go forward today, is when we talk about policies, and we'll be talking more about policies that don't have family, what is our responsibility and how do we inform our science to policy so that we will be able to improve the health of our families by having policies that really attend to our families. So I encourage us to think about that as we move forward. Remembering our legacy of Florence Nightingale, who encouraged us to consider family members as important for our care. So as nurses, we have a strong legacy. I would really also like to reinforce that if we had only done what Florence Nightingale did all of these 200 years since her contributions to nursing, is that she used data to inform interventions. And we're all well aware of what she did in Crimea. She also presented her data in different formats. She presented her data on her findings to the Queen in one way, and to the medical, the physicians on the battlefield in another. The important thing is she used data to change policy. And that's what I would, a legacy of hers that we often don't remember or know, and she's by some considered the first statistician. Some years ago, I proposed a criteria for research of families, and that there is a conceptualization, meaning what is family is the first criterion, who is family or definition of family is the second, and that our science should advance our knowledge of family functioning and structure, and that our research questions all align. And this is just a reminder how, for the consistency in all our science, it should be building on the same factors. Our fifth criterion is, I believe, as a practice discipline, our research should be relevant to our practice, and of course, that we inform policy. When I had the privilege and approached by Dr. Janice Bell a few years ago to review and revisit the criterion, I added an additional one. And my concern has been, as I work with scientists around the country, that our research, as you develop one proposal, you don't really frame the evidence of how what this current research is doing to address the gaps in the science and advance the science. So I've added the criterion that I felt that all of our research proposals should really show the gaps and moving forward and advancing the health and well-being of our families as we inform policy. So what the criteria of family conceptualization, what is family? And by really looking into and considering the conceptualization of family within our research and practice and education, is that it should provide a knowledge of how families develop, the different family forms. And on the right is, what is family? Well, you can consider family as the environment for the family and family members. It's a unit of health, and we can use this for policymakers, saying, if we really looked at family, it can be a major unit of health of the health of our countries. Family is a social institution, and some would identify that family is the etiology of health, and some would see in some families that it really is the etiology of illness within the families. So what is family? These are things that each of your, as you proceed with your practice and with your research, identifying what is family. Does it make any difference that we have a conceptualization of family? As I mentioned, it should inform all aspects of our research, but how can we replicate and really advance science if we don't know the basics of the conceptualization of family in that research? If what is family is not identified, it is difficult for us to replicate that research or move our science forward. Also, by knowing how the researcher has conceptualized family and what is family, it gives us a point for interpretation. And it should, again, inform practice. So really, lacking conceptualization is a gap in our research and weakens our research for moving it forward and informing science. Importantly, what is family? And part of what is family is differentiating family from other groups. And different people, but consistently through family science scholars for decades, have identified these characteristics that differentiate a family from another group. From a policy standpoint, when I was at the National Institute of Nursing Research and we were developing codes for all the grants that we funded, I kept encouraging that we had family as a category in the coding. And I had to convince my colleagues in the Institute that family was not another group and it really needed to be coded. And it took a while, but I finally convinced them. And again, recognizing why and how family is different from other groups is important. So who is family? A year or so ago, I contacted many of my family nursing colleagues and asked what their definitions of family. And these are some of the definitions that I'll be presenting in the next few minutes. But one that is most consistently brought forward is who members define as family. And I'll be talking about if you do that, how does that inform your structure and how you design your research? If you're saying whoever the family says is family, and every person you engage in your study has a different definition of family. So how do you deal with that? I focused a lot over the years is that the functions of family. And yes, we should know structure of the family, but it's really, is the family able to meet the functions of the family? So that is an important distinction when you're looking at families. Others, including the Veneer Institute in Canada, frames family within the roles, and not what families do, but what they look like. So again, it's a more neutral definition of family. So in definitions of family, the characteristics, as again, is how do our families differ from other groups? And boundaries are another thing that distinguishes our family. And in Ghana, the definition is who eats from the pot. And if you think about that in relationship to boundaries, culture, it's a very strong definition of family. It's also, as Dr. Hines mentioned, I've been working in the genetic world for many years. I'm not a genetic expert, I just get it, and I know the importance. So there is the biological, but we need to be thinking about what's happening in many of our countries where a family member can send in their DNA sample and find out that they have multiple additional family members around the world. What does that really mean, and how does that affect our perception of our family and the boundaries of our families? And as Knafel and Dietrich talk about, is the structure components. And one of the things in thinking of our research is there as a theoretical definition that we may use for family in our research, but operationalize differently when we conduct the science. So why does it matter that we have a definition of family? And that is, we know who was studied. You know, was it an individual family member? Was it a dyad? Was it the whole system? Again, if we know who was studied, we know how relevant that research is to how family is perceived in each of our countries. Without the definition, how do you generalize and know if the findings can be generalized? How do you replicate a study if you don't know who was the family in the study, who was really engaged in the study? And in a Scopy review by Dr. Knafel and colleagues, they identified that researchers don't delineate the sample criteria. So you really don't know in many of the studies on the family management style, who was family. You don't know who participated. And again, how do you advance science when this information is lacking? So there are strengths if we use the definition of whatever the family says is family. It's neutral because it's defined by the family and not by the researcher. We include all family forms. It avoids bias. But what are the realities? It requires that we have our data, our demographic data, and how we collect it, and what's included in it needs to be flexible and inclusive of all possible ways the family members may respond. We have to define or engage in our interventions multiple family members. How do we do that? If that varies by each family, that is a consideration. Dr. Deborah Gross, an outstanding researcher in family interventions that have informed policy, mentioned to me some time ago that when they implemented their intervention in the family project, Chicago Family Project, they engaged all family members who wanted to be involved in the intervention. And they found that as a very important way to increase the opportunity for success of their intervention. So if you limit your definition or you're not clear of who you're engaging, you may miss the opportunities, such as Dr. Gross did, in engaging whoever the family determined as family and who would be engaged in meeting and participating in the intervention. We have to, if we include, this is our definition of family, we have to be able to engage multiple family members, have measurements that can be used for multiple family levels, individual dyads, etc. Our analysis must be robust to include the variance we're talking about when we include and the complexity of this type of research. I'm not being naive about this. I know this is not easy, but you must have these conceptualizations if you're going to move forward. So if, as Dr. Knaffel and colleagues reported, most research does not report really who was in the sample. So how do you find family in research? You can determine, try to interpret who is family by the research questions and aims of the study, by the inclusion and exclusion criteria, by the purpose, sampling, and the interpretation of findings. And Dr. Lorraine Thirsk, who I believe is on this call today, is using natural language and clinical data in Canada to see how often family is mentioned in the charting of our clinicians. And a very important study. And if you're really looking to evaluate where's family in our clinical settings, this is an important way, because as Dr. Norma Lang and others have said over the years, if it's not documented, it didn't happen. So I commend Dr. Thirsk on this approach and feel it can be very informative as to where we are in inclusion of family in our clinical practice. I've had the privilege in working with Dr. Hines and being peripherally engaged in a very important study she has done and funded by NIH, National Institute of Nursing Research, on what is being a good parent to a child who is seriously ill. So in that research, the question is asked, if you can please share with me your definition of being a good parent of your child at this point. And this is one family member's response, and I've highlighted in the response two mention of families. So you may think, oh, great, I can now find family in this study. Well, many of the interviews I reviewed had no mention of family, but that may be part of the data you want, is X number of the participants identified family as part of being a good parent and how many did not. And another example from this very important study, a respondent said that good parent is in the best interest of their child and the family. Again, an important context when we're caring for families with serious illness. This parent also talked about that they had a very close family that was very supportive, but sometimes that got in the way of their decision-making as parents. Very important data. So even if the study was not intended and defined as a family study, we can gain information about family. The work of Dr. Kathy Kelly is very important. And so how do you find family in the research? And when she was doing her work on step families with children with cancer, she was having difficulty identifying who is family and who's engaged in the decision-making with this child, and found that if she used a genogram and putting the child with cancer at the center of the genogram, she was able to identify who were the decision makers, which was the point of her study in the care of this child. And also she was able to identify the households where the child was cared for with the treatment of cancer. So again, she did define family in her study, but in other studies that don't, this would be one way of finding your family. Another way to assess who is family would be to use the family circles, which were put out by Gabe Smilkstein in the 80s. And his whole intent of the family circle was to try to get family residents to think family. And that's as far as he thought it was going to go. But as many of you know, the family circles have continued to be used. the use of family circles and having a family defined family is that the size of the circles in the family members are important, and also at times family members will place family members out of the circle. Again, very important in learning about who is family and family boundaries. I've mentioned that one of my interests in family functions is knowing who can you define family by who meets the functions. It's important to recognize through the family science scholars that these are the traditional carryover for generations, carry over through cultures. So they're neutral, and a foundation for understanding family is what are the family functions that are being met. And we cannot assume that there's multiple family members, that these functions are more apt to be met, or assuming that in a two-person family, that these functions will not be met. So in the work of Dr. Knaffel and others, in looking at children with chronic conditions in a meta-analysis, she added to I would say, the generic definitions of family functioning of the protection of the vulnerable family members, which they labeled parenting plus and vigilant parenting. So, again, the advantages of using family functions is that functions are neutral. It engages in both the structure and function of family members. You can learn about the family and its relationship with the environment, which I'll talk in a minute about how critical it is that we know the context of our families. And if you have a functional definition of family, it may inform you who to include in planning the family interventions. And it broadens our focus beyond structure, which in many of our studies, we seem to be stuck on structure and forget the other dimensions about family that may inform and move our research forward. However, the issue becomes, how do you measure family functioning? It's important to recognize that most of the family functioning measures that you still see being used in research were developed in the 70s and 80s, and often are just measures of dyadic relationships. And that's why, while I was at Wayne State, a research-intensive college of nursing, in the 70s, developed the family functioning measure that wasn't dyadic and that truly looked across many family functions and used a measure of how much is there and how much should there be to, again, neutralize the responses of family members. More recent work on family functioning is the work out of the family management measure development through Dr. Knaffel and Dietrich. Other ways of measuring family function would be to using ethnography or observation, echo maps, family circles, interviews. So there's a variety of ways, but again, any of these measures you use and approaches you use and actual measures of family functioning, they need to be aligned with your definition of family and what is family. So in looking at family functioning, again, with the good parent data from Dr. Hines' work, this is a response from one of the parents, and look at all of the family functions that are mentioned in this family member's response. So again, existing data can be a source of being able to define the functions of family members. Family structure. It's important, and I cite the work of Kuntz, that in the United States, there's no single dominant family structure that has existed. And the nuclear ideal that has been purported in our country as a traditional family really has only predominated for a small part of our history. Families in the United States have always been diverse. And she purports that, and you'll see other examples, that it's really inappropriate to classify a family structure as new, non-traditional, or traditional, or as alternative. That is labeling and putting in perspective and negating the fact that variation in family forms has always existed in the United States. Knowing the family structure may explain variations in the intervention, and by knowing the family structure and who meets family functions may become who you include for the intervention. And again, as I mentioned, using genograms, family circles can help you in identifying who to include in the intervention. So, okay, I've said you must do this, you need to do that, you're not going to advance the science if you don't. So how do you make that work? So I've modified and got some input from Dr. Kelly that I think. I also worked with Dr. Knopfel on this. So the basic premise is that the research question guides all aspects of the study, from the conceptual underpinnings, exam, so forth. So the research question is, what are the patterns of family decision-making for children with life-threatening conditions in step families? So the conceptualizing defining family, I determined that for this example, that the family is 3 generations of persons described by family members engaged in decision-making for the child. What is the family? What's a conceptualization? Well, what is the family for this study is who is the source of care and support for this child. Who is family is also identified by the inclusion and exclusion criteria. And this work could be classified by Sadani, who puts forward phases for doing and developing intervention research, that this type of study would be foundational or phase 1 of that effort. So moving forward with this example study is, as Dr. Kelly so wisely did, was she applied the genogram to determine family structure for who is the decision maker for the child. Through this, she was able to, very importantly, identify family households in which the child with cancer might be receiving or was receiving treatment. Very important to know for the integrity, reliability of her study. And again, her point was family members engaged in decision-making for the child with cancer. A complicated question, but with the structure she used and using the genogram guided her in the inclusion for this study. So she chose, or if you, in building off this example, you assess family function using an echo map. You would want to know the data source. Dyads based on the family function of decision-making for the child. The measures were types of data gathered from about the family unit and family members. So hopefully this example walks you through the so what of what I've been talking about up to this point. As I mentioned, colleagues are from our second workshop and then the IFNA pre-conference are working on a manuscript, putting together the knowledge and moving forward on strengthening our ability to develop family intervention research. They've identified what is missing, that we often, the unit of care of the family is not included in the research, that truly family-centered care as the primary approach is lacking, and our studies usually put the disease first and not the point of family care first. And they also found that conceptualizations of how professionals with supportive families are not consistent. What they proposed is describe how interventions need to be systematically developed from foundation to the RCT, the clinical trial. And again, I refer you to the work of Dr. Deborah Gross now at Hopkins as a phenomenal example. And if you're looking for that work, putting in Dr. Deborah Gross's name, the Chicago Parent Project, and you will be able to identify all the phases they went through in developing from their early research to their clinical trials, and now how that research is integrated into policy in the Baltimore and other school systems. We really need to know how interventions work. And oftentimes, the way our studies are designed, that doesn't happen. This has been proposed for years, but we are still lacking in much of our research on looking at cost effectiveness, and our interventions need to be looking broader, and I will speak more to that in a minute.
Oh, Vicky's in there too.
And while we're developing the interventions, as Dr. Gross did in the Chicago Parent Project, involve families in the intervention as we're doing the development of our intervention. So the importance of family context. This diagram on your right shows the complexity of the family context and the complexity of the environment. And it identifies the physical environment, man-made, economic, et cetera, and also policy. And what's important to recognize, and came forward in the conference I attended just before this workshop, is that you have to have political will. So our responsibility in this country is often to enable policymakers to see the advantage and the strength of inclusion of family in our policies and using family data. And we need to generate the political will. I believe with attention, the social will is there, but the political will is not there to really look at families as a basis for our policy. One reminder over the years is that if you have 4 family members, this is complexity of families, and this is why I think a lot of people don't do intervention research. If you have 4 family members, you're looking at 15 different relationships with dyads, triads, whatever. But you have 6 family members and you've gone to 63 relationships. So again, just a reminder of the complexity of our families that we need to be aware of, but not negate our doing this important research. I've mentioned that the importance of using the echo map as part of assessing the complexity of the family environment and our family functions. And again, the genogram is center to the family echo map. And this can be very helpful in planning discharge for children from the hospital and just knowing the context. And the importance of the echo map is it also shows you the relationships and strengths of relationships, and again, can guide an intervention. The social determinants of health is getting much more attention now. And it's important to recognize, while there are 5 domains in the social determinants of health, which are presented by the World Health Organization and Healthy People 2030 in the United States, is that policy is the primary determinant of all of these social determinants of health. From education stability, education, healthcare, all of this is based on policy. So yes, we need to pay attention to the social determinants of health, but we also need to be attentive to the fact of what is the policy behind these social determinants. So knowing that, how do you take this information forward to tell policymakers why family is important? Pointing out that family health data can be a leading indicator. And Dr. Sarah Stanson, the dean at Johns Hopkins University, made the point of when you protect the health of families, you are protecting the health of the country. So it can be approached that may get the attention of policymakers, reminding how our families can be harmed by stressful conditions, and all of the data we have for COVID is a perfect example. And again, we want to prevent adverse outcomes, and by addressing the social determinants of health with a family lens, we can do that. It's a reminder to our policymakers that our families are the best known, humane and economical way to care for multiple generations, the financial support of our families, and the care of other family members. what the policymakers care for are what are the outcomes and for whom does it matter? So that's what you need to be taking forward is the so what and why it would be important for a policymaker to include family in their agenda. So in the United States, an early definition of family, which is still being used today, was the Hill-Burton Act, which was used to fund hospitals, encourage the care of persons person with inability to care, and we still call it the uncompensated care. And this definition continues to be used in the States and was last updated in 2021. However, there are only a few hospitals that really still fall under the Hill-Burton Act, although this is the primary definition for family that comes forward in the United States. Our Department of Justice does include a definition of Native American. The Census Bureau, which in looking across countries, is a major time when the definition of family comes forward. So in your countries, if you're looking for how is family defined, you may want to look at the latest definitions used in your latest census. In science policy, I look for definition of family through NIH. And although there's not a definition of family, very, very importantly, is this program announcement that is out. And the point of the research is that it's risk and protective factors of family health and family level interventions. So any of our researchers in this country, now a program announcement means that it's ongoing. It's an effort by the NIH to say, this is an area we're interested in. We encourage you to do research in this area. It means if there's two proposals evaluated and rated at the same level, the one that deals with this program announcement will be more apt to be funded because it deals with an interest of NIH. For nurses in the United States, there's a lot of attention to the new strategic plan by the National Institute of Nursing Research. And some people are finding it difficult because there's the broader discussion in terminology, and the research is expected to show outcomes, but in the basic language of the new strategic plan includes families. So we may, rather than look at what isn't there, be open to seeing how does my research really build on the direction of the National Institute of Nursing Research. In Canada, there are a Family Equal Act put forward for parenting, and it was interested in reading that as an outcome of that Families Are Equal Act, that families with there are 4 parents named on the birth certificate, which includes the biological parents and the partners of the biological parents. So that's where Canada has been on this. The Canadian Constitution again identifies the Indigenous populations from the country. The Canadian Bar Association is trying to inform policy by identifying changing definition of the family. Now, I would disagree that they should be, I don't think they should say non-traditional families. I think they should be saying all families, whatever, not calling anybody non-traditional, but it is an attempt by the National Bar Association to inform and move family policy forward. And there's been work in academia with efforts to, again, move forward the importance of family. And the Veneer Institute, as I mentioned earlier, defines family by its roles. In Japan, colleagues have shared that in their textbooks, the definition of family is usually based on our Western textbooks. But there is a legal dictionary and civil code for family. And Dr. Honda has pointed out that legal boundaries are so strong, it is difficult for unmarried couples to have rights and a single person in Japan cannot adopt a child. So think about how knowing this can inform your research, the structure of research, the definition of families, and how you may need to be in working with policymakers to change the perspective on who is family. And this is from the Civil Code in Japan and how detailed the code goes in identifying the relationships of family. The point of bringing these forward is to reinforce our responsibilities in knowing the perspective on family at our federal levels in all of our countries. And again, in Australia, as shared by Dr. Lindsay Smith, there is a definition based on the census, but he reported but didn't give me an answer on it's not the shared understanding. So there are other perspectives. Again, in Australia, they do acknowledge the Indigenous Australians, but it is important also that there is a resource through the Canadian government on family facts and figures. So if you're doing research in Australia, you would want to use this information in informing your science. In searching for the national information on family, I found that in Croatia in 2017, a law was put forward in defining family that if you're a couple without children, you are not considered family in Croatia. So how do we move this forward? How do we use our policy to improve our research and the outcomes for our families? As I've said for years, the purpose of our research of families should be to support policies and programs that inform policy and programs that support the functions that our families perform. To do this, I really encourage that all of our research needs to look upstream. And as I've mentioned, the determinants of family health and well-being is policy. So we need to be aware of the policies. And as you are caring for a patient family at the bedside or in your clinic or considering your research and an intervention that you're proposing for a family with a child with cancer or for interventions for elderly persons in needing care, think about why they are where they are now and how their needs, if policy had been in place, care opportunities in place, may have prevented the situation they are in at this point in time. So I encourage you to think about this. It has been identified that most of our interventions are modest and unsustained. And again, it's because our research lacks context. This slide just reminds you that if you're doing research of children with obesity, the depth of what needs to change in policy to improve the outcomes and prevent obesity with children require public policy from food production to trade laws. Who cares? What is the political and social will that you want to change the policies in food distribution? In the United States, we have so many cities in food deserts. How do our families get healthy food? In the unfortunate situation in Buffalo, the primary location in a low-income Black community for food access is closed. So what happens in those communities? So again, this is the importance of policy. And if we design our research in a narrow focus, only looking at right here and now intervention, we are missing the opportunity to really have broader impact. So our policymakers expect us to do all of these things. And the good news is this is nursing. The focus of our discipline is to improve care, is to improve care outcomes. And a policymaker was quoted yesterday as saying, what are outcomes and why should I care? Why does it matter? Our research can reduce the demand for care and the burden of disease. So we are well positioned to bring our science forward to meet the policymakers' expectations. Remembering Dr. Woolley from Research America, our research does not speak for itself. We must frame our science in messaging that policymakers will understand. And when we go to our policymakers, we don't just say, give us more money, which we are known to do in nursing in the United States, but you say, with the funding that I have had from the National Institute of Nurse Research or from this foundation, this is what I've been able to do. But if you provide more funding and you provide funding for education of families, this is what more we can do. So you start with what have you done with what you have and what more could you do with more funding, not just give me more money. For those of us engaged in policy, it's starting with and may be sustaining, it's the staff members of our congressional people that you may have the sustained relationships with. But what your goal is that you're on speed dial with your state and members of Congress, that you're known as the expert. Oh, this is a question I'm not sure about. I need to call Dr. Bell. So here, I'll use her as an example. As I mentioned, coming from the second workshop, this outstanding brochure has been developed by members some are on the call today. And it was a resource for engaging families in research. Dr. Pulvis attended a workshop at NIH just after our second workshop. And she thought, oh, what's missing is giving families guidance and engaging in research. So if you're interested, I hope at some point this goes on the IFNA website. At the present time, if you're interested in getting a high resolution print copy, it's available off of this Google website. So what's the point of what I've been saying today? Obviously, we need to operationalize the definition and conceptualization of family. As I mentioned, if we're not doing it, how do we start on the journey of research if we're missing the basic elements to tell us where we're going and why we're going? We need to conduct our research is to improve the outcomes. But what I found in nursing and other disciplines is that we are cautionary on declaring the so what of our science. So I encourage you, when you're communicating with policymakers, you're out there saying, my science does. The result of the science is. It really bothers me when I look at all these websites that say, the focus of my research is. No, folks, what is the intended outcome? What is the so what of your science? As I mentioned, looking upstream, look at the population of families that you're working with in your practice and your research and say, why are they here? What could have been done to prevent them being here? That is the broader look and the point of your intervention. As I mentioned, I just attended this Academy of Science new first land bringing forward this project. And they're looking at federal policies, how they contribute to racial and ethnic health equities. I encourage you to go on the NASM website and continue to follow this because they will take public comment as they move forward with this project. It will be a perfect opportunity for you to say, where's family? Why is family important in this? So we're never done. Our road is always under construction, but I wish you well. And we'll take questions after Dr. Bell's presentation. And for those interested, I can make the slides available. Thank you.
Dr. Feetham, on behalf of all of us, thank you for a very scholarly presentation. Our privilege to have been learning from you. And I so appreciate your analogy of the journey, the conceptual and empirical foundational work that will prevent our research on family from coming to a dead end or being on a one-way highway. So thank you so very much for all your words. I do believe that if we can improve the health of a family, we can improve the health of a community, and then all of the nations that we collectively represent today. And now it's our great privilege to go to our next master teacher, Dr. Janice Bell. Welcome, Dr. Bell.
Thank you very much. Can you hear me?
Yes, indeed.
Okay, great. Now I just need to figure out my slides. Eileen, can you help me? Where are my slides? Where can I find my slides? Oh gosh.
They should probably be just at the bottom of your screen.
Okay, share screen.
Yep.
Good. Okay, I'm getting there.
And then select your monitor
Select my monitor.
and have your presentation open.
Select my monitor. No.
Great. Nope, it's working.
Oh. Okay.
Now bring up your presentation. Open your presentation.
Okay.
Let's see, it's over. Where's your PowerPoint? Let's see. I can
Share.
I know we can do this. Maybe if you stop sharing for just a moment. Stop sharing. Open your PowerPoint. Open your slides. Just a moment. We have backup for all of you. We've got backup if we need one.
I can see my slides, but you can't probably.
Not yet, but that's okay. As long as you've got your slides, now you're going to select the share screen in the Zoom. At the very bottom of your screen, you're going to see that share screen again, just like we did, the green box.
Screen.
Select the monitor again.
Monitor again.
And then at the bottom of the right, there'll be, like it says now, right at the bottom, it'll have a little blue thing that says share my screen.
Okay.
And you just did it, so it should be right there.
No.
If you would like, Dr. Bell, you are welcome to send your slides to one of us and we can pull it up for you.
I have her slides, but I know we can do this, but I just, are you not seeing the little button at the very bottom that says share my screen now? Not the green one, but the one next to the monitor.
This is on my laptop.
Yep.
It only has one monitor, Eileen.
Yeah, it is. Right, you just have to highlight that monitor, that screen, highlight the one monitor screen. Click it. You just did it.
Sorry, I think you're probably going to have to help me by just pulling it up and.
Pulling it up? Okay.
Yeah.
I can do that.
Okay.
Let me do that. You pull, I'll just, hold on. Okay, I'm going to share my screen. Can you see,
I can?
let's see, whoops. A second.
Because it's on your,
Okay, let me get,
needs to be on the
Okay.
horizontal.
can you
And
see
you
it?
may want to share it on your other monitor. It looks like you have it on a more narrow monitor.
Oh, right, okay, hold on. Let me stop sharing and pick a different one. Let's see. Now are you seeing the right one?
Yes,
Yeah.
it looks better.
Okay. All right. I'm trying, however, display settings. Swap presenter view. Okay. How's that? Does that give you just the slide?
Yep, that's great.
Okay, Janice, just cue me then. Just say next slide, and I'll be ready to advance it. And still, if you'll
Okay.
watch the chat.
All right. Well, that's great. Thank you so much for your assistance. It's been 2 years of home alone. I feel a little bit like this is all just very new, and obviously I need a lot more practice with the slides. I want to say a special thank you to Pamela Hines and her staff for inviting both Suzanne and myself to this lovely invitation to speak to family nursing research and family research. It's just been an immense privilege of mine to have been mentored by Suzanne. Her presentation today really, she always reminds me, doesn't she, of you? Doesn't she remind you also that this is family nursing is yes about practice and yes about education and yes about research, but at the end of the day, it's always about policy. And so, Suzanne, thank you for that amazing reminder of the complexity of this work that we've all been called to do. And I am really curious to know from you folks in terms of like, who has been your cheerleader? Who has been your mentor in your work to develop education, research, practice in family nursing? Or for those of you who are not nurses, and I'm so thrilled that our International Family Nursing Association has been able to recruit numbers of members who are not nurses, but who have found a home within our International Family Nursing community through the International Family Nursing Association. So I'm curious to know who have been your mentors, who have been your cheerleaders, who have been your kind of foundational leaders. And I have to say that for me, Suzanne Feetham has been that person in so many ways. And I'm just very grateful and thrilled to be sharing this opportunity to work with her today with this presentation. So next slide. So the Journal of Family Nursing has been on a remarkable journey, really, in terms of the history as I know it, is that in very early on in 1988, Lorraine Wright at the University of Calgary had this vision for calling together colleagues who were interested in studying family, conducting research with family, working with families, teaching about families. And so she organized the very first International Family Nursing Conference in Calgary, Alberta, Canada. And I was privileged to, be part of her team who helped organize that conference. And we had 300 plus people from around the world join us. And that was just like astounding. And so we thought, wow, this is fabulous. And so 3 years later in Portland, Oregon, in 1991, we had another conference. How exciting was that? And then there was talk about like still another conference, maybe in like Montreal, Canada, 3 years later. And somewhere along the line, Suzanne Feetham, so many different cheerleaders of mine, including, let's see, who would have been some of that original team? People like Suzanne, I'm just blocking on all the names, but there was just like a team of family nursing scholars, seasoned leaders who decided that maybe it was time that there was a journal of family nursing. And at that point in time, there was nobody, we put out calls to various groups, and there was nobody really who was very much interested in the topic of family nursing. And then we had this amazing conversation with a woman by the name of Christine Smedley at Sage Publications, who said, yes, I think this might be very timely. We've never done this before around family nursing, but let's think about, Sage is interested. And lo and behold, on a summer afternoon in 1990, that would have been about 1993 now, I received a call from Christine Smedley from Sage to say, would you be interested in being the journal editor? And I said, what? I'm just a newbie here. I just have these amazing leaders and mentors who have convinced me that working with families is like really important, but like to do a journal, I know nothing about publishing, and I know nothing about, the work of all of that. And she said, no, you've been vetted, and we'd really like to extend this invitation to you. And so what an amazing journey this has been for the last 27 years to have guided and watched and cheerleaded and encouraged the development of the science of family nursing through this particular journal called the Journal of Family Nursing. And there really are, there are a number of journals that obviously 124, if you look at the ranking, 124 nursing journals in the world in nursing, in science, and then 122 in social science as classified by the people who do this ranking. And then, of course, we're also ranked, this journal is also ranked in terms of the family studies group. And you can see that, I don't know, we hit it out of the ballpark in 2020 with an impact factor of 3.818, ranked third out of 124 in nursing science, 3 out of 122 journals in nursing social science, and 10 out of 47 in family studies. So what an amazing and thrilling journey this has been for me, but mostly for our family nursing community, and the growth that we've seen in family nursing as a result of having our own journal and being able to be open to lots of different kinds of publications that have really advanced the science and the practice of family nursing. So this every year, of course, there'll be in late June, there'll be a new impact factor score put out in 2021. And, we're all standing on guard here to see what that will look like, to see whether or not we'll keep some of those great numbers or whether or not they'll be different. Anyway, it's been thrilling to be part of this. And so I just really want to say a big thank you to Sage Publications for really providing our family nursing community with this amazing opportunity very early on in our development, and the persuasive leadership that was shown by numbers of colleagues, including Dr. Feetham, Dr. Catherine Gillis, Dr. Shirley Hansen, Dr. Lorraine Wright, Dr. Marilyn McCubbin, and the list could go on, but many, many early family nursing leaders in North America who made this kind of magic possible. Okay, next slide. So I just want to begin this presentation by just saying a huge thank you to my family nursing community and those of you who are part of our family nursing community but not nurses. I think it's fabulous that we have had this amazing growth in the membership to include incredible professionals who are doing this kind of work with families but outside of nursing. So first off, I just need to recognize the Journal of Family Nursing editorial board of 29 members from several countries. I'm looking at my notes here, from 29 members from 8 countries. And the mission of this journal really is to extend knowledge about family nursing and family health and transform practice with families. And if I had a particular bias, it would be, and a preference, it would be that all that we do is about, at the end of the day, hopefully transforming practice with families. There's no other nursing journal that claims an exclusive focus on family health and family intervention and family healing from a nursing perspective. And I'm delighted that the Journal of Family Nursing editorial board has been able to include non-nurses, like you see in this picture, just a small collection of the Journal of Family Nursing editorial board. We have Luke Russell, who is not a nurse, but who is a family scientist, Cristina Garcia Vivar from Spain, Noriko Yamamoto Mitani from Japan, Kyoko Kamibepu from Japan, Christina Wakaraisen from Thailand, Joel Anderson from the United States, who again is a non-nurse, but who has been a major contributor to our international family nursing work, family nursing organization work. And a huge thank you to the reviewers from around the world who are very central to the work that this journal has been able to accomplish over the last 27 years. I'm really grateful to reviewers who have always are asked to review manuscripts and provide, useful feedback, and the ways that you do that in addition to all of your other work. I have an amazing group of reviewers for the Journal of Family Nursing, always looking to include new ones. So if you have not yet reviewed for the Journal of Family Nursing and would like to have that experience, I welcome you to to become a reviewer. Write me a note. And then, of course, heartfelt thanks to authors who have also chosen the Journal of Family Nursing as a place to publish their work. So next slide. So, there's been a explosion of literature around families and family connections and family health and family relationships in the context of mental and physical health in particular. And I love this quote by Wampler and Patterson, who have been quoted as saying, extensive data from multiple sources document close connections between family relationships and mental and physical health. So next slide. I see somebody in the chat who just said, how do I become a reviewer? You simply send me an email if you wouldn't mind and tell me about your interest in terms of working with us on the journal and and we'll give you a review to do. There's generally I like 2 to 3 reviewers for every article, and so that there's an opportunity and an opportunity to learn and grow too as you review for the journal and get to see other perspectives other than your own in terms of the review that you do. Luke Russell, who's I think on this call today, has written a beautiful piece in the Journal of Family Nursing called Capturing Family Complexity. Excuse me, I'm just going to take a drink here. And I love his quote here: family nurses and scholars who work at the intersection of health and families might more thoroughly capture complexities of families that are frequently overlooked, ignored, or forgotten. This is complex work we do, but that we are really at that intersection of health and families, and that we can address the complexities of families. And Suzanne has made a pretty compelling call for that today. Can I see the next slide? So I'd like to argue in this presentation that family nursing research requires a very synergistic interplay between theory, research, practice, and policy. That yes, we, and as you can see in this slide with Dr. Janet Dietrich, working with a family, that we really do believe that health and illness is a family affair. And we know that nurses and larger systems recognize the value of family assessment and intervention. But how is this achieved? And so we've been growing the science in terms of trying to understand what is that synergistic interplay between theory, research, practice, and policy. And an increasing number of the Journal of Family publications have moved beyond just description to actually examining practice and examining the therapeutic conversations that nurses have with families and family members to address their illness. I say in my work to address their illness suffering. And so you can see a lovely recent publication by Alfaro Diaz in Spain, Brokema in the Netherlands, and Jarofsky Owen in the United States, and Petter's daughter and Svava's daughter, my colleagues in Iceland, and then my own work with Dr. Lorraine Wright in terms of our work to talk about interventions for families using a model for practice called the illness beliefs model. And then, of course, Lorraine and Maureen Wright's work, Maureen Leahy's work around the Calgary Family Assessment and Intervention Model, which is one of several models out there for assessment and intervention with families. But I think what's unique to us as a group of scholars, practitioners, educators, is that we're always thinking about multiple systems simultaneously. There's always that sort of synergistic interplay between the theory, the research, the practice, and the policy in relation to family work. So now our next slide. That kind of systemic interactional thinking, I think, is the hallmark of what family nursing is about and family nursing intervention is about. But to be able to capture that then in the research has been challenging. And here you have sort of a list of some of the key kind of publications that have been done about family intervention. By Chesla, by Shields, by Kazak, by Martyr, and some of those were some of the larger systematic reviews that were done. And then, of course, the notion that individual patient outcomes benefit family systems interventions and individual versus individual interventions. And then family level relational interventions improve relationships between family, patient and family members. So a number of different ways to be thinking about the conduct of research and the particular focus that has been shown, and this slide is really just talking about some of the sort of the foundational research that was done in terms of that kind of showing the value of that systemic interactional thinking. The next slide. So what about the work that our community of family nursing scholars have been invested in? And there's been some lovely pieces across 27 years in the Journal of Family Nursing, where we've really been showing the evidence for growing the evidence about the value of family nursing in family nursing practice in particular for families and nurses. And again, this nurses believe in caring for families, but often lack the family intervention skills. But we believe that these skills can be learned, mentored, and coached. And so again, look at the authorship there of scholars from, again, from Spain, from the Netherlands, from Canada, from Switzerland, from Denmark, from Sweden, contributions from a lot of different countries, and so many very compelling pieces of work here about that these skills can be learned and mentored and coached. And then another point, the brief therapeutic conversations offered by the family increase family satisfaction with care and improve nurses' satisfaction in their work. And this whole focus on the notion about what is a therapeutic conversation, what is a therapeutic family nursing conversation, how do we learn that, how does it get taught, how does it get evaluated, and what impact does it have on families? And that's been some of the work that has been done, again, by family nursing scholars around the world. Next slide. And then another sort of aspect that I think has been really important to pay attention to, and Hardy and Sabi and Anderson raised this question about, so each of us in our own professions who are interested in families in health and illness are doing their own particular work, but what are some of the common specific and systemic processes that can be drawn upon by all family clinicians and researchers, regardless of the professional or model orientation? So again, being able to look across disciplines to be asking about some of the specific process factors that can be used to that are common across programs of research, and really growing that evidence for what is the process of change in terms of the interventions that we offer to families, assessment and intervention. Next slide. So there's been this really lovely development more recently about looking at family intervention research, and the idea that what's required is an understanding about how that knowledge is translated into practice with families. So the phraseology that has been used by numbers of researchers in this area is really talking about family nursing knowledge translation. And so in the knowledge translation that's being done, you're asking about how nurses within a variety of contexts learn the actual skills necessary to practice effectively with families. And there's a lot of new publications related to this. And what we're understanding is that nurses desire to work with families, but they don't necessarily have the skills. They don't necessarily have the larger system support to be able to do that, and are, I think, this is an area that needs a lot more work in terms of trying to understand how do you take a skilled practitioner who is very good at what they do and get them to be able to move to think about families and to be able to practice with families. And even then when they do, how are they supported and rewarded within the institutions? Because as we know, across the world, really, for the most part, I'd argue that nursing is still very much concerned with the individual. I mean, our charting is about the individual, our conceptualization often stops at the individual, and we think about the family as being very, very not essential, and in fact, sometimes even increasing the labor of nurses around providing good care. But there are those folks who have really picked up this notion that there can be amazing work done around increasing nurses' capacity to practice effectively with families and to actually do some research about that. And I'm thrilled, and you can see, Alfaro Diaz's work out of Spain, Lutik's work out of the Netherlands, and Naff and Campella's two beautiful pieces of research out of Switzerland. Okay, next slide. And then there's this whole other piece that, I mean, we're getting from like little picture to big picture now about, the pieces that are required in terms of knowledge development within family work, and the notion about the value of the systematic reviews and the meta-analyses that are an important type of evidence that need to be part of our mandate. So what are some of the common factors that contribute to the effectiveness of intervention, family nursing intervention in particular? And what are the clinician and family factors that contribute to the effectiveness of the family nursing intervention? And I think some of that, I think we're going to see more of that kind of focus as we continue to grow and evolve the science around family nursing intervention. Okay, next slide. So one of the things that I love to remind all nurses and other professionals who work with families in the world is that our International Family Nursing Association has done this marvelous job of developing what we call position statements. And the position statements that have been created are now 5 in number. The International Family Nursing Association began in 2009 in the world, and has been a wonderful addition to the growth and scholarship of family nursing, I believe, in the world. And these 5 IFNA position statements are, I think, some of the best work that has evolved out of the work of having an actual International Family Nursing Association. So we have the position statements on generalist competencies for family nursing practice, a position statement on advanced practice competencies for family nursing, 2 position statements on education for family nursing, in family nursing, both at the generalist level and at the advanced level, and then also a new kid on the block, which is the beautiful work that's been done around a position statement that has linked family, let's see if I can get this right. I'm just trying to think of the actual formal name of it. Oh, thank you, Paula. Paula was one of the people who did some of that really hard work to get that position statement developed. Thank you. Planetary health and family health. And what a timely topic that's been. And so we're doing some work within the International Family Nursing Association work to monitor the citations to these position statements. And there is a page on the IFNA website that shows the dissemination results to date. But these two particular position statements, the position statement on generalist competencies and the advanced practice competencies, have had the most robust response in terms of being cited by our colleagues around the world and others. So the last slide is, these next section of slides are just about opportunities that I would like to invite you to think about in terms of the Journal of Family Nursing, opportunities for you and your colleagues around particular topics or particular focus pieces that are really important to you. The Journal of Family Nursing has offered and developed many special issues over the last 27 years. But all of a sudden, in the midst of COVID, I don't know whether people were just had more time on their hands or whatever, but all of a sudden we have three special issues underway, which is very exciting for me. And so guest editors Joel Anderson and his colleague Yingling Yao have just put the final strokes of their work together in terms of a special issue on the impact of COVID-19 pandemic on family-focused care of people with Alzheimer's disease and related dementias. And that particular issue has gone to press now. Joel and his colleague Yingling have just written the guest editorial, and this piece of work will be published in the Journal of Family Nursing August 2022 issue. And then we have another really exciting special issue underway, and that's supporting structurally diverse families. This has been a fabulous topic, led by the guest editors, Dr. Luke Russell, Dr. Larry Ganong, and Dr. Jonathan Beckmeyer. And the call for papers has been out for some time. They have received a robust response, and that group of papers will be published in the November 2022 issue of the Journal of Family Nursing. And then lastly, another really exciting special issue. I can hardly wait. The call for papers is June the 15th, 2022. It's a special issue called the Multidisciplinary Health-Related Family Synthesis Research. And the guest editors are Dr. Kathleen Knaffel from the United States and Dr. Veronica Swallow from the UK. Dr. Swallow is the current president of the International Family Nursing Association. We're so thrilled to see the International Family Nursing Association beginning to spread across the world, and leadership now being represented on the board of directors for this organization with people from across several countries. And anyway, this special issue is the call for papers is June the 15th, but I would imagine that if you have not yet seen this call for papers and have a family synthesis research that you would like to report, there certainly would be an opportunity for you to put your hand up and say, yes, we have something in the works, and the deadline for that can likely be extended by a little bit. So those are that's my sort of overview of the contributions of this Journal of Family Nursing to the advancement of family nursing in the world. It's been such pleasure, such a pleasure to be part of this development, to watch the uptake of family nursing in the world, and to see that this particular way of thinking about being helpful to families is larger than just with nurses. It can extend to include other professionals. And it's just been an honor and a privilege to be the journal editor of this journal for 27 years now, and we're only just getting going.
Oh, Dr. Bell, I love your spirit, and I thank you sincerely for taking us into the future, the near future, and the more distant future for family research. Many, many thank yous for that presentation. I'd like to invite all of our participants to insert questions into our chat box, and Eileen, Stella, and I are monitoring that. I'm going to go ahead and get us started with a question for our two master teachers. And that is, I very much appreciated the comments about the research that is ongoing about being a good parent to my very ill child. And both clinically and conceptually and empirically, I have been struck by, even when a family is described as having abandoned another part of the family or is absent from the life of a family, they seem very present to me. They are still spoken of with feeling. And I wondered, how would you suggest documenting the felt absence of a family? How would you suggest depicting it with the methods that you have mentioned as capturing the family dynamics and family presence? So that part of the family that is described as missing, absent, even in stronger terms as having abandoned the rest. Your thoughts on that, please.
Thank you, Pam. As you bring that forward, I think of a phenomenal scholar, unfortunately, who's no longer with us, who was doing excellent research in Oregon. And her research was under the framework of intergenerational. And that even though not physically present, our perception of health and our experiences with health that our family members bring into the hospital or wherever we're interacting with them is informed by previous generations. I think particularly in some of our minority families where the experiences with the health system have never been positive. And so the perspective and lack of trust is well documented in some of these studies of, again, the intergenerational perspective. So I think I was addressing your question in the light of, if we think of that context and never assume that our current family that's in front of us, and I always encourage people that when they get a child or an adult, they always think of layers of family behind them. That's how I try to get people to think of family, and that they're always there, they're always present, and they always have influence. So I think we didn't talk about that today, Janice, and we haven't seen it, I don't think, other than this wonderful colleague some years ago of framing some of that research and deliberately looking at that intergenerational influence on family beliefs and family responses to health and illness.
Thank you for that thoughtful response. Dr. Bell, would you like to add anything or go further?
Well, I think that whole notion about, the abandoned family and how family is conceptualized is, I mean, they still are family, right?
Yeah.
And so you're always, I would imagine, from a clinical perspective, of course, I would be, starting to be very curious about what that was about, and are there any wishes that it could be different, and if so, how would you go about mending or re-including or reconceptualizing family? So I mean, I think those would be very tender important conversations, is particularly in light of, particularly as they are connected to, is this family suffering around that? That would be the criteria for me as a clinician to be asking, you know, is there a lot of suffering about these cutoffs and that kind of history, and does that then open the door for some sort of intergenerational healing of some kind?
I very much appreciate that clinical perspective too. Thank you, Dr. Val, very much. Other questions from our participants, please, if you would like to put them in the chat, or if you raise your hand, we will also try to see your hand.
I would like to know if people disagree with anything I presented today.
And I think while we gather our thoughts on that one, Dr. Feetham, Dr. Kim Mooney Doyle has a comment. Kim, go right ahead.
Oh, Pam, I had just sent you a message about an essay I read an essay I read about families who are bereaved, what they call themselves, because there are terms for people and families who are bereaved, and but parents who are bereaved don't have a term. So it was an essay written by a bereaved parent that the term was semper parente, always parent, to kind of conceptualize that, you know, and thinking of the good parent work and the families we interviewed are thinking of that.
Oh, so fitting, Kim. Thank you.
You're welcome.
Susan Keller, please go right ahead with your question. Oh, beautiful.
Gonna unmute myself. So I just wondered if you were, especially Dr. Feetham, if you were at all worried about our current crop of policymakers defining family, because I have some concerns about that.
Thank you, Susan. You always raise excellent questions. Yes, and that's why we need to be engaged. We have recently learned that one of our Supreme Court justices doesn't think science should be part of policy. So that's of some concern. So I don't take what I've been saying about informing policymakers lightly, but I think we have a responsibility in how we frame the message and be very aware if legislation that is coming forward is moving in a direction that is not defining family as we see it as a broader perspective. If the legislation would be coming down the pipe that would be in the perspective only of the nuclear family, which, as I mentioned, is never the dominant form. So I totally understand your concerns, and which to me reinforces our responsibility that we need to be engaging our policymakers, pay attention to the policymakers, being sensitive to legislation that's been passed in Texas and my state of Florida that can be having tremendous effects on families with transgender children. And so that's where I feel we have a responsibility. And that's why we need to be stepping forward, whether it's at the school board level, at the state level, meeting with our legislatures when they're in our states from Washington, but we have to frame the message. And some years ago when we were in a similar situation, I think we can never ignore the legislators we might disagree with, that we find common ground and work with them, and that they will see us as resources and be contacting us. And again, a phenomenal colleague, Dr. Elizabeth Thompson, was on Senator Harkin's family or nursing advisory group out of Iowa. And she was on the speed dial of Dr. Harkin. And in our language, when we became an institute from a center, was language that Elizabeth had been asked to review the proposed legislation And the wording was because of Elizabeth's input and knowledge of family or knowledge of nursing. So I'm not negating your concern at all, and it beeps up my heart a bit to be thinking of responding. But I do think that's the point. We have a responsibility. And I'm trying to communicate with my legislators on a regular basis and find common ground and meet with their staff and others in person. Thank you. Very, as usual, Susan, a good question. You can see why I love being at Children's.
Thank you, Susan. Thank you, Kim. Others, please.
Dr. Hines,
Yes,
Eileen.
Eileen.
I appreciated Dr. Bell's comment about the fact that in our nursing notes, there's an absence. And although I'm not an advocate for increasing the intensity of what nurses document, I think that the putting forward the idea that we don't do a good job of making family assessments readily visible in our electronic health records. I know that on admission, we gather information about the family or about who makes decisions, but I don't think, and I wonder if it isn't a systematic issue, that how we were instructed to what goes into a nursing note isn't a part of the origin of the problem that doesn't seem, that kind of discounts what is it that we're documenting. I just wonder if Dr. Bell would like to comment on that.
Yes, well, I absolutely support your comment. I think that is around the world a similar phenomenon of how is it that we have such an individual orientation to care that's around documentation that does not necessarily always provide. And so there have been brave people in this world, in Japan, I'm thinking, in Switzerland, that have advocated for at least a genogram on the patient chart, and some of that has been taken up. Some of it not so much, or it goes for a time, but then it drops off. But I think these are the things that are sort of fundamental, I think, to the work that we're all doing, and that is to see a change in that kind of, that if you believe that families are important in health and illness, and that there needs to be obviously a lot more clinical work being done to teach good skills, good assessment skills, good intervention skills, but then there needs to be that whole paper documentation too around the patient chart and how that comes together. It's been an ongoing concern for many, many years. Some places have been able to address it more successfully than others.
And I agree that our nurses don't know how to do family and miss the cues because they don't know what they would do with the information. And so, and if Nicole, we were on yesterday, we were talking about it, that it had to start in nursing and having family and nursing education. Dr. Thirsk was on a minute ago, and I'm just, if she's still there, to respond about the documentation and what you're finding and what thoughts might be on the clinical use of family.
Sure. Thanks, Suzanne. Yeah, I didn't put my camera face on today, so I've been leaving my video off. But yeah, it's interesting. In Canada, I think we're a little bit further behind with the electronic health records, but it does create a barrier to inserting the information like genograms into our documentation. But the database that I'm currently looking at, family is showing up. We're looking at it in critical care. And there's a variety of ways that nurses are documenting about families. So whether it's gathering information from the family member, providing information to the family member, a lot around substitute decision-making and end-of-life care planning, those kinds of things. So it is interesting to see how it is being documented. Ideally, what we would like to see is that type of documentation has a link to some outcomes. So In this case, only patient level outcomes because we don't have that connection to the family, but it is showing up somewhere. And I'm sure that there are probably nurses that are doing more with families that's not getting captured in these notes, but it is there a little bit. So it'll be interesting to explore. We're hoping to look at another database in another year or two to see how it's different in other clinical areas. Yeah.
Thank you so much for
Mhm.
that.
One of the, I'd just like to mention some years ago at one of our council meetings at Children's National, when the research of our pews, and identification of children's at risk, and the neuroscientist who was doing the data for that project spoke at our council meeting and showed how the data were being used and how they influence the care of the child. And I still remember that council meeting and our nurses saying, now that we know how our data are being used, I don't think collected the data of how did they change their practice and not bundling their charting, but charting on the child throughout their time on the unit, because that was a very profound presentation on how important it was and how their data were used to give the early warning signs of children in difficulty and that needed intervention. So
Thank you, Dr. Feetham. And may I thank both of you and ask if both of you would please look at a really important comment in the chat from Dr. Tolley as well about measurement, and is family management likely to show change over time, or is it more stable? We're very happy to send your responses out to everyone who's registered along with the link. But on behalf of all of us, gosh, thank you so much. This has been a really nice conversation for our third family research workshop. It is precisely what we hoped would happen with the foundational messaging about the science and taking us into the future about what will be needed next to be addressed within our conceptual and empirical and clinical work. I thank you both for leading us so very well, and may we keep learning from you both. Thank you. And may I thank everyone for their participation. Please take good care of yourselves.